Here is exactly what we're covering today. Decoding types of shock, neurogenic versus anaphylactic shock, the sepsis severity spectrum, sepsis 3.0 and resuscitation, and we'll wrap it all up by solving clinical vignettes together.
All right, Section 1, Decoding Types of Shock. Let's get right into it.
So, looking at the overarching matrix of shock types, a really fascinating pattern emerges right away. With hypovolemic and cardiogenic shock, your cardiac output naturally falls, right? So the body compensates by clamping down. This shoots up the peripheral vascular resistance, or PVR, which is exactly why the patient's extremities go cold. But what if they have warm extremities? Well, that means PVR has dropped, pointing to massive vasodilation. It's also super interesting how early warm septic shock presents with a hyperdynamic circulation and normal JVP, but late cold septic shock actually depresses the myocardium so much that it mimics cardiogenic shock.
Next up, we have obstructive shock. Think of this as a massive mechanical roadblock. Imagine a massive pulmonary embolism or cardiac tamponade, where rapid fluid accumulation around the heart literally stops it from relaxing. If the heart cannot dilate to fill up with blood, your preload just drops to zero, and cardiac output halts entirely. It's a pure plumbing issue. Distributive shock, on the other hand, is all about where the blood pools. If it redistributes out to the peripheries, leaving the patient with those telltale warm extremities, it falls right here. The blood is basically just sitting there in dilated vessels instead of making its way back to the heart. This is the absolute hallmark of neurogenic, anaphylactic, and warm septic shock. Then we have endocrine shock, which is honestly a bit of a physiological wild card. You'll see this in patients with severe hyper or hypothyroidism or acute adrenal failure. It presents as this really messy combination of distributive, hypovolemic, and cardiogenic shock all rolled into one. It's rare, sure, but you absolutely have to keep it in the back of your mind when the standard vitals just aren't lining up.
Moving right along to Section 2, neurogenic versus anaphylactic shock. Now, it turns out we can distinguish between two nearly identical types of distributive shock, neurogenic and anaphylactic, with just one vital sign. Both of these feature massive vasodilation, warm extremities, and a terrifyingly fast drop in blood pressure. So what's the secret? It's the heart rate. Neurogenic shock, like from a severe spinal injury, causes a total loss of sympathetic tone, meaning you get bradycardia. But anaphylactic shock, that's driven by histamine release while the sympathetic nervous system stays totally intact. So you end up with tachycardia because the heart is frantically trying to compensate for the fluid shift.
Okay, let's shift gears to Section 3, the sepsis severity spectrum. You can really just think of this as a deadly staircase. We start at step 1 with SARS, which is the body's generalized systemic inflammatory response. That could be from trauma or an infection. Step 2 escalates to sepsis, which is defined as SARS plus a known localized infection. Step 3 is septic shock. This is the terrifying point where pumping the patient full of IV fluids completely fails to raise their crashing blood pressure. And then the final, tragic step is MODS, or multiple organ dysfunction syndrome, where 2 or more distinct organ systems completely shut down. Obviously, that carries a massive mortality rate.
Let's look at the exact parameters that define SARS. You need 2 or more of these for a diagnosis: an abnormal temperature, an abnormal white blood cell count, a respiratory rate over 20, or a pulse over 90. Now here's a crucial pro tip. An incredibly important but often overlooked metric here is having greater than 10% band forms in a peripheral smear. Do not forget to watch out for that one.
Now for Section 4, Sepsis 3.0 and Resuscitation.
Sepsis definitions have actually evolved pretty recently, making our diagnostic goals much more rigid. So instead of calculating a massive, complex SOFA score right at the bedside, we now use QSOFA, the Quick Sequential Organ Failure Assessment. And it is brilliantly simple. A systolic blood pressure under 100, altered mental status, and a respiratory rate over 22. Hit 2 or more of those, that immediately signals a critically poor outcome and means you need to intervene aggressively right now.
Also, under the new Sepsis 3.0 guidelines, the definition of septic shock has become incredibly strict. It is now definitively diagnosed by the persistent need for vasopressors to maintain blood pressure, combined with a serum lactate level strictly greater than 2 millimoles per liter. Why? Because that elevated lactate level is the alarm bell telling you the patient's tissues are literally starving for oxygen.
And remember, the clock is always ticking here. The goal is to hit very specific hemodynamic targets within the first 6 hours of resuscitation. We want a central venous pressure between 8 and 12, a mean arterial pressure of at least 65, urine output reliably ticking above half a milliliter per kilo per hour, and a mixed venous oxygen saturation of 65% or higher. Your first move, aggressive IV fluids. If and only if fluids fail, do you bring in the big guns, inotropes and vasopressors like dopamine or norepinephrine.
All right, let's put this into practice. Section 5, Solving Clinical Vignettes.
Let's look at case number 1. We've got a 44-year-old male, 3 days post-op with an ileal perforation leak. He has a pulse of 100, a high white count of 15,000, and a respiratory rate of 20. His urea is 70, but he's conscious and oriented. So ask yourself, does this patient meet the criteria for SARS, and how far up that severity staircase has he climbed?
Breaking it down, it's pretty clear the patient has SARS. Why? He's got tachycardia and an elevated white count. There's also a glaring focus of infection from that post-op ileal leak. So SARS plus a known infection, that equals sepsis. Now, his urea is 70, which points to kidney failure, but he's totally conscious, meaning his CNS is still intact. Since only one organ system is failing, he hasn't crossed the line into MODS yet. So our definitive diagnosis here is just sepsis.
Okay, consider this next case. A 65-year-old diabetic patient comes in with a massive infection, Fournius gangrene. His pulse is 110, blood pressure is 90. But crucially, his blood pressure refuses to budge even after aggressive fluid resuscitation, so he started on dopamine. His liver functions are marginally deranged, but other parameters are normal. What's the diagnosis?
Well, the patient clearly has SARS and a known focus of infection, so we are automatically at sepsis. But the absolute throwaway clue here is that the patient required dopamine because fluids entirely failed to raise his blood pressure. That fact alone definitively locks our diagnosis in as septic shock. And since only his liver is marginally deranged, he hasn't hit MODS yet. So septic shock is the final answer.
Finally, take a look at case 3. We have a 26-year-old trauma patient who's crashing post-transfusion. He has a pelvic fracture, he develops a fever, a liguria, and hypotension. But there's a highly specific, honestly chilling symptom here. He is bleeding directly from his IV line, even though his central venous pressure remains completely normal. What is happening here?
The deductive logic here is just brilliant. We know for sure it isn't hemorrhagic shock from the pelvic fracture because his CVP is totally normal. If he were just bleeding out internally, that CVP would completely plummet. It's also not a fat embolism because those typically take 24 to 48 hours to show up. That highly specific symptom, bleeding straight from the IV line, points directly to a sudden catastrophic coagulopathy. This patient is suffering an acute hemolytic reaction from an anaphylactic mismatched blood transfusion.